Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
I had really one niggling concern about the FLAURA trial, and that was that 30% of the patients on the first generation agent never got anything afterwards. And my experience is that these patients usually progress pretty slowly, and you can never count on somebody having the T790M mutation. And for the audience, before Tagrisso was approved first line, it was approved second line and has clear activity in the subgroup of patients who have this T790M mutation when they progress on another EGFR inhibitor. So it gives a backup plan, but only for a subset of patients. To me, it always concerns me when a global trial has a group of patients that do less well than I would expect in my own practice. But again, the trial was the data. So what's your interpretation of this? I know you've thought of it.
Yeah, well, I think we have to be very cautious of that. I think we all assume that our patients would do better than the patients who go on a trial. And this goes back to multiple studies. I think if, again, you and I have been in practice for a while, we've got the maintenance trials, right? The maintenance trials where patients got their first line chemotherapy and then either continued the drug as maintenance or stopped it. And when we got the results from those trials and we saw that the patients who stopped it, most of them weren't able, or very few of them were able to go on to get the second line chemo, we all said, well, that would never happen in my practice. But if you look at who enrolled on those trials, these were our colleagues, multiple institutions who treat patients very well. And so I think we have to be very careful when we say, oh, but it wouldn't happen like that way for my patients, that the trials speak otherwise, right? And so the
one thing I wonder about, and I just don't think we have data for, is seeing better what the patterns are in a global trial, because maybe, but we have seen in some studies of EGFR inhibitors versus chemo that in China, the crossover rate's 50% or 52%. And in Japan, it's 100%. And so I think that the reality is there are different healthcare systems, there's different economics, there's different practice patterns, and that I'm totally for, let's see what the data show. But I do feel like we haven't been granular enough in asking that question of, is there a difference between how the data that were obtained from one part of the world versus another?
No, and I agree. And I also, when we think about our, everything is going to be looked at from the filter of what do we see in our own practices. And does every patient I start on osimertinib Tagrisso have a response? Of course not, right? But most of them do. Have I had to stop some because of toxicity, such as heart toxicity known as QTc prolongation that we see on their EKG? Rarely, but yes. Right? And are there patients where their cancer starts to grow at a shorter than the predicted average? Of course. And so for them, I'm thinking, oh, well, they would have probably been better off if I'd started them on erlotinib Tarceva and then waited for them to progress and then gone on this. But I don't know that. Okay. And I think that's where FLAURA, for whatever flaws, you can always point at flaws in a trial, but the fact that there was that clear overall survival benefit in a trial setting where patients are usually watched more closely than they are when they're not in a trial, right? Yeah. So theoretically getting better care overall, there was a survival benefit. And so I think at least here where I can have the luxury of whatever I prescribe, my patient's going to be able to get, from insurance or from assistance from the company. It's different globally. Right. But here I can say, yes, that's what I would do, but we want to still keep pushing that envelope and trying to see what else we can add.
And I think that you could make the argument of regardless of what we think we could do in the Lake Wobegon experience of all of us being better than average. The FLAURA trial says that because you can't control everything that's going to happen, or at least in a broad population, whether it's the US or globally, the way that you ensure the best outcome is to have people get the best drug up front rather than have contingencies before you get there. That's the surest way. Carolyn, you have your own thoughts, and I'm also interested in how much or how little the CNS, the activity against brain metastases and the protection against future brain metastases weighs in on the appeal of Tagrisso over other options for you.
Yes. So I do think that the brain metastasis coverage, both for treatment and prevention of brain metastasis, has been a real critical improvement for Tagrisso osimertinib over the other treatment options, and just the tolerability of the drug as well in my clinical experience is superior to the other treatment options as well. And I think the thing that we have to be really careful of is sort of the anecdotal experience. And I think that weighs heavily on patients as well, because they see online all of these very impressive anecdotal experiences and are very tempted by, well, let's do this treatment and then this treatment and but being all things considered equally, we really have to use the scientific data that we have in a randomized controlled trial where all of these other variables have been controlled as much as is possible, because you can always find an amazing outlier in an anecdotal experience. And the point that you're making about the 30% didn't go on to receive a second treatment in the control group, I think that is really important. It has a lot of implications for the results. And I think also it's important that it automatically leads us down the road of we have to start with the strongest treatment possible. And that really, I think, is going to lead us for development of future studies and future trials, where we're thinking now of the trial of, all right, we know of gefitinib with bevacizumab. What about gefitinib with chemotherapy now in two separate trials? What about osimertinib, Tagrisso with chemotherapy? What about osimertinib with bevacizumab, and so on?
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, Takeda, AstraZeneca, and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.